Yeah, thank you very much. And good evening, good day, good morning to everybody. Thank you so much for putting up this amazing format. And thank you even more for giving me the opportunity to present here. Thanks to all of you, Nikki, Zoran, and Evert, also to the kind introduction. So the next 20 minutes or so should give you an overview on the updates on the management of concussion. These are my disclosures. I have no potential or actual conflict of interest in relation to this presentation, which is truly about what you can use systematically in your clinic or in your daily work on the pitch to be a little bit more familiar with the concept of concussion, because that has changed quite a bit over the past couple of years, how a concussion is diagnosed and how a concussion is treated. So if we just start with the most basic question, what is a concussion? We could not fill this 20 minutes. We could probably fill days or weeks, because we used to think that Glasgow Coma Scale and the different severities of the TBI reflected by the Glasgow Coma Scale reflect everything so nicely, and everybody is probably familiar with utilizing and using the Glasgow Coma Scale. But as a matter of fact, the concussion is the mildest form of a mild traumatic brain injury. So mild traumatic brain injuries are relevant. We know this, and even the milder form, the concussions, are clinically very relevant. And to make it even more complicated, the mild traumatic brain injuries in themselves are organized or can be seen or should be seen as a spectrum. Because on the left, in the acute setting, we have those subconcussive blows, or a little bit more appropriate, the repetitive head impact, which do not cause clinical symptoms. In the middle, we have those concussion or mild TBA cases. And on the right, we have the mild TBA cases where we have a slight substance deficit that we can see or appreciate on CT or MRI scanning. And then it gets even more blurry when we look at the chronic spectrum of the results of those, the relevance of those mild traumatic brain injuries, with entities like chronic traumatic encephalopathies or persistent post-concussion symptoms. And then if we ask ourselves, like, how much do which type of mild traumatic brain injury contribute to a chronic condition like this? So of course we cannot cover this all, but if we think about football, we deal with subconcussive blows or repetitive head impact a little bit. We talk about concussion, and of course we worry about the long-term health of our players. And this number two is really what we talk about now, like what is happening and how should we clinically deal and manage concussion or the mild traumatic brain injuries here. And if we think about what happens during a concussion, those concepts have quite emerged. And we used to think that the brain swaps back and forth, and we have coup contra coup pathomechanism leading to our clinical picture. But as a matter of fact, it's not that easy, especially in those mild forms of mild TBI. We rather have a different pathomechanism that is depicted here, because the brain is not a homogeneous mass that swaps back and forth, and the brain is actually connected to the inside of the skull via the heart meninges. And just because of these anatomical peculiarities, when a translational force is applied to the skull at one part, focally towards the brain, what happens is that those areas in the brain that are connected to each other start rotating against each other. And this counter rotation on a large screen, when the cerebellum rotates against the cerebrum, or in the lower part, and you have the when you have the upper dorsolateral brainstem rotating against each other, or within those brain lobes and the brain lobules, what happens is that this translational force is translated or is changed into rotational forces. And those are bad because they work diffusely inside the brain. They are they shed the myelin sheath, and they cause what is called a diffuse axonal injury. And those axons, the role of those axons is to provide communication between different areas of the brain. And this communication is impaired in concussion. So what concussion really is whatever you want to do, and you need an intact communication between many areas in the brain, is going to be impaired, which is a concept that is not as easy as a focal neurological deficit, for example, that we see in larger severities of traumatic brain injury and other neurological pathologies. So if we translate that into a clinical concept, what do we see? What are the signs and symptoms that we see? This is a flower that I always think beautifully depicts everything and displays everything that's happening. But for some reason, me as a neurologist, I'm pretty much the only one who likes these kind of complicated things. So let's make it easier. This concussion may affect multiple clinical domains that all rely on intact communication. And if you reduce the clinical domains to cognitive issues related to fatigue, anxiety and mood issues, headache and migraines phenomena, ocular and vestibular deficits, you cover almost all the signs and symptoms that could happen as a result of a concussion. And if you look at the two important modifiers that we have, one is sleep. Please do never overlook sleep, because sleep is so important and so often disturbed after a concussion. And also problems with the cervical spine. You pretty much cover everything. But those are the domains that need to be covered and assessed in your initial approach, if you look at the patient or if you look at the athlete, and also, and probably even more importantly, in the regeneration and the treatment after concussion. Of note, alteration of consciousness is everything but obligatory. Just imagine that approximately only 10% of cases of concussion present with alteration of consciousness. So if you just rely on that, you're going to miss out on a lot of concussions. So this is the complicating part. And hopefully we get to the easier part now, because there are clinical tools that are in parts even evidence-based, but mainly consensus-based, that you can use, which is the SCAT in its 6th version, or the SCODE, which has been newly introduced last year in the 6th version. And I'm going to show you how to use those. Those are tools that have been developed by the Concussion in Sport group and are freely distributed all over the world. Right now, they're only available in English, but several translations will be available of those clinical tools. So if we think about how a concussion is diagnosed, it's not diagnosed differently from almost every other thing that we have and every other disease that we have in medicine. We take an appropriate history. We perform an appropriate physical exam, which is a little bit more special, or of course different from an exam of a knee joint, for example. And we might need some additional exams or an additional workup, especially if we want to rule out other pathologies. But first, let's step back a little bit and get to the situation where you are confronted with the question of the diagnostics, or how to diagnose a concussion first, which is on the pitch. But if you think about what you have to do on the pitch and the sideline assessment, you're not really required to make a firm diagnosis. Sorry for the spelling error here. The firm diagnosis can be made later on. Your assessment should lead to an answer to the question, shall the player continue to play? Do you need a substitution in outpatient care, or do you even need a substitution in inpatient care? And what you can do once you covered all your ABCDs in basic life performance is you want to assess and protect the C-spine. You always start with the Glasgow Coma Scale, because at the point of the initial contact, you don't know whether there might be a higher degree of traumatic brain injury that's occurring. And you apply some sort of neurological assessment, which very often, unfortunately, still causes insecurities, but can be made very easy and very easily applicable to all of you, and even or especially if you're not a neurologist. And this is where the sport concussion assessment tool in its 6th version, and the immediate assessment and the neuroscreen comes into play. When you have your algorithm here, the first thing after a contact, after you observe something after a contact to the head, is, are there any red flags? And I don't want to go over all those red flags that you're probably familiar with in detail. I just want to encourage you to review all those red flags, because if any of those red flags are met, the player must be removed from play immediately for further medical investigation. And if not, you can look at observable signs. You could look at, or you should perform the Glasgow Coma Scale. You perform a cervical spine assessment. You perform a quick test of coordination and an oculomotor screen, and a very quick test of memory assessment by applying the Maddox questions. Again, I do not go into detail of all those steps. I just list them here. And Edwin afterwards will tell you how to make sense of those steps in the practical setting. But I would all encourage you to take use of those freely available tools, and maybe even practice this a couple of times, because I can promise you, you'll be really proficient and you'll be really good in applying these on the pitch the next time. Once you remove the player and you go to an off-field assessment, either in the locker room or maybe even in the medical room, a couple of other steps should be, or a couple of further information should be come into play and should be obtained here. First, the athlete background, a symptom evaluation list, and a brief cognitive screening. And those of you who know the SCAT-3 or the SCAT-5 still remember the orientation test, the immediate memory test, which should always be done with 10 words instead of 5 words. It was an option to do 10 or 5 in the SCAT-6, and the 10-word assessment is much more appropriate. A concentration digit backwards test and a concentration test where you have to name the months in reverse order. Of note, in the new SCAT, the months in reverse order should specifically named as fast as possible. And this is to introduce another domain, the domain of time pressure in some of your evaluations, which is very important because if you stress the brain, you put up some time pressure. And the modified balance arrow scoring system is quite similar to the SCAT-5 that you may know. The other optional form of the MBAS, of the balance test, could be done on foam, and the tandem gait test could be or should be performed as it is, but also as a dual task gait. And again, we want to put more stress to the brain to really find out whether the brain has been injured or not by applying a dual task a dual task here. So when you do your tandem gait test, you ask your athlete to count backwards out loud by 7th, and you see how much that slows up the pace or causes some instabilities and gait problems. And in the last step, as before, is the delayed recall. Now, the new tool that you have available now, when you see the patient in your office, when you see the athlete in your office and you want to do a more thorough assessment of brain function, is the SCOTE. The SCOTE is a sport concussion office assessment tool. It consists of almost all the elements of the SCAT-6 plus some other features, which could be divided into a couple of tests and information you should get after your first assessment, as part of the assessment or optionally. And these are, for example, orthostatic vital signs, because the autonomic nervous system is very frequently affected by concussion and unfortunately very often neglected. On the other hand, the autonomic nervous system is very important when it comes to return to play and organization of the functioning of the internal organs, especially the cardiovascular system. You have a more detailed cookbook, so to speak, how to look at the C-spine, how to examine cranial nerves, and to apply a modified vestibulo-oculomotor screening, which is a very, very important test that some of you may know as the VOMS that you could apply for concussion as well. And these are the optional parts of the assessment. If you feel you might have an anxious athlete, you can apply an anxiety screen, a depression screen, you can assess sleep, and you could also, and you actually are encouraged to also use a computerized cognitive test battery. And last but not least, very important, you're encouraged to apply a graded aerobic exercise test. This is nothing you could do or you should do on day 0 or day 1, but once you see the athlete in your practice and you can do a graded aerobic exercise test and actually see how this patient, how this athlete reacts to aerobic exercise, it is much, much easier to plan the return to sport protocol and also to guide the management and the therapy. Now, you see that these are all clinical tests, and everybody in the world is looking for biomarkers, but unfortunately, the diagnosis of concussion is still made clinically. And this is the same slide that I already showed a couple of years ago. And unfortunately, we don't have a biomarker for concussion yet, but I'm still positive that in a couple of years, the slide will look different because so much research is going on. Now, please don't forget that you may need workup to rule out a larger or a higher severity of traumatic brain injuries or other pathologies. But The diagnosis of concussion is, for example, based on a normal CT and a normal MRI scan. If your MRI or CT is not normal, it's higher severity than concussion. And you see, imaging is a very important modality. And if you look at some research, or a lot of research is done in the neuroimaging of concussion, and a lot of progress has been made, because our clinical protocols have not been developed to show us any kind of diffuse axonal injury, which is why the standard clinical protocols of MRI imaging are usually negative. But if you look at those new protocols like diffusion MRI or DTI analyses, they bear the possibility to show us the pathophysiology of concussion. But most of those studies are cross-sectionally done, but there are also longitudinal studies now. But this is where we stand. We stand at the group level, and the group level doesn't give us information on the individual level when we have an individual athlete. So we don't know the diagnostic sensitivity and specificity yet. And that's why it's not ready for clinical use yet. And similar things with serological biomarkers. You see things like the S100B or other serological biomarkers that have an okay sensitivity depending on the study, but the specificity is usually very low. And here's another a problem. If you, for example, look at a serological biomarker at the S100B, the S100B correlates with verbal memory, visual motor speed, and reaction time. So you think it's great, so I could use that. But it also correlates with ethnicity, with race. And if you control your S100B values for race, there's no correlation anymore with verbal memory, visual motor speed, and with reaction time, which is the reason why it hasn't been established as a clinical test yet. And with many, many other devices and tests that are actually sometimes quite heavily and quite aggressively marketed, you always have to ask yourself, what is the validity and reliability? What is the sensitivity and specificity for the contents that you use to test in your situation for concussion? Or even in the setting, because a sideline test is different from a test in your office, which has to be taken into account. Or for example, here, a couple of systems are out there to detect abnormal eye movements. They even have an FDA approval for the detection of abnormal eye movements and not for concussion. So if you have a concussion without evident abnormal eye movements, they might not work very appropriately. Or this one here, this has been FDA approved for 2 or 3 years now. These is a handheld device that can detect UCHL1 and GFAP levels, other serological biomarkers, within 15 minutes. But those validation studies have been performed against abnormal CT scans, so at a higher degree of traumatic brain injuries. And similar to this handheld device, measuring some electrical brain activity, an EEG handheld device tested against abnormal CT scans. Again, there's a lot out there, and if you want to use it, ask yourself how good is the data for the situation that you're looking at, but be aware that if you want to diagnose or treat a concussion, no test has been approved yet. Again, I'm pretty sure that in a couple of weeks we'll talk, in a couple of years we'll talk a little bit differently. These are probably the 2 most important things that every guideline that you find will highlight. If a concussion is diagnosed or suspected, there must be no return to play or practice on the same day. Analog to an analogy to the slogan, when in doubt, sit it out. And then the second thing is, after the initial rest, there should be a stepwise return to play and to practice. And this is really the good news. If you do this, so if a concussion is correctly treated and diagnosed, if diagnosed and treated, probably more than 90%, or at least around 90%, will have a very favorable outcome even after 2 weeks. So why is that important to adhere to those guidelines? You probably heard about the second impact syndrome, which may occur if you sustain a second hit when the first hit has not been completely recovered, or the brain hasn't recovered from a first concussion. And then there's risk of complete energetic meltdown in the brain. Now, the second impact syndrome is certainly truth, but very rare. And there's probably some sort of genetic predispositions in those very young athletes. There are about close to 50 cases published worldwide, usually in males under 20 years of age. And knock on wood, there hasn't been a second impact in football yet. So if you do your math or do the analyses, whereas the incidence is 1 in more than 200,000 athlete seasons. So this is very rare, yet still very, very dangerous. On the other hand, there's a condition that is everything but rare, because if you don't belong to those 90%, you may present with persisting post-concussion symptoms. And please note that you should refrain from the old terminology, post-concussion syndrome, because it has been recognized that this is not a syndrome at all, because it's presenting so variably between different individuals. And the best thing to prevent persisting post-concussion symptoms, which means that your signs or symptoms may present even longer than 1 month after the injury, is managing the risk factors. And those risk factors can be pre-existing, patients with a history of concussion or TBI, psychiatric diseases, headache syndromes, genetic predispositions, or even the female gender and female sex and gender have a higher risk and should be treated more carefully. This is something that I like. I don't have to present it here. I always present it outside of sport, because if you have suffered from a concussion outside of sport, your risk of developing persisting post-concussion symptoms is a little bit higher. And even after the injury, if you have the adjustment disorder, secondary gain, or bad compliance, your risk for PPCS is higher. So if you continue to play and delay access to specialized healthcare providers after a sports-related concussion, you have to expect a longer recovery, which again emphasizes the correct management of those injuries. So the last point is, what do you do? How is a concussion treated? And most of you are probably and hopefully familiar with the return to sport strategy, again modified by the Concussion in Sport group. And I don't want to go over that in detail. I would just encourage you to review it in detail and even individualize it according to the settings and the infrastructure that you have in the club, in the team, in your players that you take care of. And be aware, return to sport can be differentiated or can be divided into several aspects. You usually start with return to daily activities in school over sport and training, then return to play. And don't forget the return to performance aspect that you deal with after every injury. Concussion is no different here. And the other thing that has been shown in the literature quite nicely is don't wait. If you have access to specialized care, use it, because specialized care leads to a faster and better recovery. Why? Because concussion is a treatable disease nowadays, and treatment and rehabilitation is done quite differently from 10 years ago. We don't put people in dark rooms anymore for a couple of days until they're better, because they actually turn out to be worse. This is what a couple of studies actually have shown. Quite to the contrary, there are a couple of things that you can apply and you can do to enhance recovery. And this is the right type of sports, of physical exercise, of aerobic exercise, etc. So after 1 or 2 days after a concussion, you should think about how to expose a person, your athlete, to daily activities and very, very mild aerobic exercise, maybe even only to a maximum of 50% of your maximal heart rate. And this is truly the key. You need to find the optimal exercise, which should be subsymptomatic and should be applied individually. Then if you find this, and then if you gradually build up upon that, your chance of an enhanced recovery is very high. And in addition to that, you should think about a multimodal symptom-based treatment containing of neuropsychological interventions, treatment of headaches, sleep, cervical spine problems, vestibular oculomotor problems, depending on the clinical presentation. Very, very important. Concussion has become much, much more treatable than 5 or 10 years ago. So that's why I would strongly encourage you to collaborate with a specialized center here. My last aspect and only slide is something that we could also discuss for quite a long time when we talk about long-term health of athletes after concussion and repetitive head impacts. And I don't want to cite all the studies here. You see the important ones that came out over the past couple of years, which, by the way, showed that retired professional football players actually lived longer than the control group, but had afterwards in higher ages a higher risk of developing neurodegenerative disease. And the only thing that I just wanted to throw in here is that it's very well known that we have 12 potentially modifiable risk factors that account for about 40% of all the dementias worldwide. And traumatic brain injury or concussion is only one. And what we really need is longitudinal studies that account for all those 11 other risk factors to see what we can do to make the long-term health of our athletes a little bit better. So I would also encourage you to not judge too prematurely, but rather, if you're interested, read those studies really in detail. So my take-home messages in my last slide is the UEFA Club Competitions Concussion Charter. And most of you hopefully know that the UEFA started putting up this charter a couple of years ago, which consisted of a couple of elements, which first is baseline screening, which we didn't touch upon in the interest of time in this presentation. If you have a medical review system, use it. Educate players and staff accordingly and very, very specifically, and adhere to the guidelines in return to play or training. And probably, and even most importantly, join the pledge to adhere to those guidelines, as all the UEFA club competitions or all the clubs that participate in the UEFA competitions actually did. And with this, I'd like to thank you very much for your attention, and I'm looking forward to the question and answer session afterwards.